Hi, and welcome to our next section. It's pericardial diseases, Conrad Fisher. Acute pericarditis is defined as an inflammation of the pericardial lining. It's from almost any kind of infection, connective tissue disorder, trauma, or cancer. Any cancer that's anatomically near the heart. Any kind of trauma to the chest wall. It could be from a steering wheel. You try to eat through your chest. From blunt trauma, penetrating trauma, emotional trauma, any kind of trauma, banging against your chest. Now, virus is the most common, but any infection could do it. Lupus is the most common connective tissue disorder, but any connective tissue disorder could do it. The findings of pericarditis are unique. There is nothing else that's going to give you chest pain that's positional and pleuritic and positional and pleuritic. It gets better when you lean forward, worse when you lean back. It gets worse with a deep breath because you stretch that pleurin and it hurts me. And a friction rub is good if it's there and not useful if it's absent. In other words, a friction rub is specific if it's there. A triphasic friction rub. It's only there in 1/3. The best initial test is unquestionably an EKG. That EKG will show diffuse ST segment elevation everywhere and PR segment depression. Nothing else like it. ST segment elevation everywhere, PR segment depression. That is unique. So there are several unique things from pericarditis that are going to be there. Acute pericarditis is distinguished from an acute MI by, first of all, there's no MI that causes ST segment elevation everywhere, and there's no Q waves. But you know what the problem with the Q wave thing is? Q waves don't happen until later on. It's kind of like saying your contraception is effective. Why? Because you didn't get pregnant last week, did you? Well, that's not a very good way to be able to judge whether or not it's there. But you don't get Q waves. It's true. You do get T wave inversion later on. The major issue is the PR segment depression, ST elevation everywhere is specific enough. The best initial therapy is unquestionably non-steroidals. Ibuprofen, naproxen, Sulindac. It doesn't have to be indomethacin, and I don't have to rip a hole in my stomach with indomethacin just to make you happy, do I? Colchicine prevents recurrences. It's not clear whether you should give it the first case. Probably not. But the case will be very clear for you. Say the person comes in, and they've had this twice this year, and you say, add the colchicine. The next piece is pericardial effusion. Now, pericardial effusion is liquid weeping off the pericardium that accumulates within the pericardial cavity and can compress the heart. Any kind of pericardial disease can cause a pericardial effusion. So any infection that can give you pericarditis can cause a pericardial effusion. Any kind of transudate, exudate, it's not really that meaningful to call them transudate and exudate here, although it follows the same patterns. It does. A transudate is a protein that's low. An LDH, that's low. Congestive heart failure, overhydration, low protein levels. Exudate, pericardial injury. Yeah, but it's better to say, you know what I mean, infection and cancer. Serosanguinous, same as it is in pleural effusion, tuberculosis, and cancers too. So any infection, virus most common. Any connective tissue disorder, lupus is the most common. Any trauma, any cancer that's anatomically near the heart, and any one of them can cause an effusion that can compress the heart. Hemopericardium is the same thing as hemothorax. Trauma, man. Dissection, rupturing things, exploding things. Aliens coming out of your chest. Myocardial eruption, bleeding, coagulopathy. And the pericardium, if you expand it slowly, you can put 2 liters into a pericardium. If you put in 5 milliliters a day, 10 milliliters a day, that pericardium will expand. You put liters in there. But 50 or 100 milliliters acutely and you're dead, dead, dead. If it rapidly accumulates, as little as 50 or 100 milliliters will kill you. The echocardiogram is the best initial test. It's the most effective thing. Seeing large effusions, the heart swing around in there. Well, electrical alternans is really on the EKG. See, electrical alternans is really an EKG finding. Electrical alternans is not what you see on the echo. Electrical alternans is an EKG finding. You don't see electricity on echo. So the echocardiogram showed an effusion. Ooh, but we want to know if there's tamponade. Not enough to see if there's effusion. Hey, what compresses the fastest, earliest on the echocardiogram? The structure's on the right side of the heart. The right atrium, the right ventricle. The right atrium, the right ventricle. Do they compress in systole or diastole? Well, it must be diastole, because you can't compress something that's already compressing, can you? In systole, they're already contracting. So how could I contract? It's like trying to break up with somebody who just broke up with you yesterday. You broke up with me, I'm breaking up with you! Well, I'm already contracting, I'm moving away from you. No, I'm going to compress you! Too late. Now, if they're trying to fill you, if it's filling, then you can try and say, I reject you. But see, it's right atrium and right ventricular diastolic collapse. That's the earliest finding of tamponade. Right atrium and right ventricular diastolic collapse. EKG shows electrical alternans, big complex, small complex, big complex, small complex. The heart flops backwards and forwards in chest, big complex and small complexes. Diagnosis you see when it's chronic. When it's chronic, you can see a water bottle heart, which is one where it flops out for both sides. You see, that's a water bottle heart where it would flop out back to both bilaterally to both sides. Now you might say, how can you tell that apart from four-chamber cardiac enlargement? And the answer is you can't. But not just you can't, I can't, we can't, they can't. No, we can't. No one can tell. But remember, that's got to be chronic. If it's acute, you're just dead. If it's chronic, it's got to stretch. It can accommodate 1 or 2 liters. Pericardiocentesis is the best initial therapy for tamponade. You put that needle in when there's a sign of right atrial, right ventricular diastolic collapse, and you follow it up with a window, cut a hole in it, and it drains out through the pleural space. What's the most common wrong answer? You see a person with distended neck veins who's short of breath, and you say, let's give him some diuretics. You mean physician-assisted suicide? No, diuretics would kill them. Tamponade. Fluid filling, easy to screw that up. After all, they're short of breath and they got JBD. Easy to screw that up. How do you not screw it up? They have a pulsus paradoxus. Pulsus paradoxus, clear lungs. Pulsus paradoxus, clear lungs. Don't give diuretics. You will kill them. Cardiac tamponade is a super-duper emergency. It's an effusion that presses the heart. That tamponade can be from any of the causes of pericarditis, cancer, infection, idiopathic things. It doesn't matter, TB or infection or cancer. It doesn't matter if it's hemorrhage. It doesn't matter if it's a wound. What matters is it's enough fluid to squeeze your heart. The etiology can be you had a pericardiotomy or uremia. Now, boy, if you're in the kind of place where there's uremia and you're getting pericardial tamponade, how do you do that? Because you're a person who didn't go to their dialysis or you're newly diagnosed with renal failure. You can't get it with dialysis because dialysis would stop it because you get rid of the uremia. You can get radiated, and it happens. Yes, it happens. Or any connective tissue disorder. Point is, it's not the etiology, it's based on the severity. It's not the etiology, it's based on the severity. It's got enough compression. It presses my right side. It's got enough compression. I think I'm going to die. The shortness of breath, fatigue, and orthopnea won't tell you you've got tamponade. What will tell you the closest thing before you put a catheter in there or do the echocardiogram is the pulsus paradoxus. Normally, you inhale, and what happens? The venous return to the right side of the heart. Venous return to the right side of the heart will increase. And the heart will just get bigger in external diameter, but not if it's compressed with fluid. If it's compressed with fluid, it won't get bigger in external diameter. So the right side will get bigger, and the left side has to get smaller. And the problem is you live off the left side of your heart. The neck veins will distend, but there'll be clear lungs. There'll be bad enough shock to get hypotensive and clear lungs and decreased heart sounds. And you better get it right, because if you think it's congestive failure, you're going to give them a diuretic and kill them. Clear lungs, pulsus paradoxus. The treatment of that tamponade is first you have to see the echocardiogram where you will see the right ventricle and right atrium having diastolic collapse. Cardiac catheterization is usually not necessary, but you will show equalization in diastole, equalization of all the pressures in all 4 chambers in diastole. The treatment is a pericardiocentesis. You put a needle under the xiphoid and put a needle in it and suck out the fluid. In the same way, 50 or 100 mLs of fluid in acute circumstances is enough to kill you. Removing 50 or 100 is enough to spring you back to life. Then later on, you put in a window to drain it out. The next section of constrictive pericarditis is a diffuse thickening of the pericardium, and it happens, it's an anatomic problem. It's a chronic infection, chronic inflammation. Constrictive pericarditis is very unusual. It's the rare person who has a chronic tuberculosis infection. You'll see it. They will describe the patient as being an immigrant from a place that has a lot of tuberculosis. It's thickened and it has an anatomic problem. You can't fill. It can't fill. It can't fill. And since it can't fill, the cardiac output's limited. The filling pressure goes up. There's abnormal diastolic filling, so the fluid backs up into the ascites, big liver, big spleen, big edema. The etiology of constrictive pericarditis is the same as the etiology of all the pericardial disease, any chronic infection, inflammation, any trauma that happens, any inflammation like lupus or polyarteritis nodosa or Wegener's granulomatosis can cause constrictive pericarditis. The reason it's rare is it's very rare to have a chronic virus. That's why it's got to be something like tuberculosis, which can be around for a long time. The symptoms of constrictive pericarditis would look just like cor pulmonale. You'd have shortness of breath on exertion and orthopnea. You'd have big liver and big spleen, big ascites, and big edema of the peripheral vessels. And you can't distinguish it unless they specifically told you there is a knock. The signs of constrictive pericarditis, an increase in jugular venous pressure on inhalation. That's Kussmaul's sign. You have an increase in jugular venous pressure on inhalation, and that's more with constrictive than it is with tamponade. There is a pericardial knock in some people, but it's just like the rub. It's only there in 1/3 of patients and easily can be confused with an S3 gallop. The heart sounds are distant. That's why this whole muffled heart sound thing is way too vague to be useful. The EKG shows low voltage, but you might say, hey, fishy, low voltage could be from somebody's obese. You could say low voltage can be from tamponade. Low voltage can be from just somebody who's big. It's COPD. That's true. That's why it's not good enough. The external heart size must be normal. But what you see on an X-ray is you see calcifications. And what you see on the CT scan is calcifications and thickening. That's really unusual. That's where you see a pericardium that's a half an inch thick. Cardiac catheterization. This is one of these absurd things that's left over from before them being CAT scans and MRIs. We don't have to do cardiac cath, but it would show you a marked Y descent, sudden drop, and also, just like restrictive cardiomyopathy, you see a square root sign. In other words, on a catheterization, you can see a big increase suddenly in the pressure, and then it flattens out, square root sign. And there's equalization of all diastolic filling pressures. But this whole cardiac cath thing is not as important as an imaging study like an X-ray or CT or an MRI. Constrictive pericarditis is easy to mistake with restrictive cardiomyopathy. You can't ultimately tell them apart till after you do the echocardiogram and an X-ray or CT. The restrictive cardiomyopathy will be clearly seen on an echo because the wall will not move. In constrictive pericarditis, the walls of the myocardium will move. That's the big difference. And in restrictive cardiomyopathy, the CT scan will show a normal thickness of pericardium. The last part of the pericardial section is to say, well, if acute pericarditis is an inflammatory functional disorder, it's got an inflammatory and functional presentation, pain that's positional and pleuritic, and a rub. It's got a functional test, EKG, showing ST elevation. It's got a functional treatment, pericarditis. Use a non-steroidal for inflammatory functioning. If tamponade is a hemodynamic presentation, and you see a hemodynamic presentation like tachycardia, hypotension, distended neck veins, and pulsus paradoxus, it's got a hemodynamic treatment, which is to remove fluid. Constrictive pericarditis is an anatomic problem. You have a change in the pericardial anatomy to make it thicker and more calcified. You have a change in the anatomy of the body where you see a big liver, big spleen, big liver, big spleen, big hemorrhoids. You have an anatomic test like an X-ray and a CT scan. And you have an anatomic therapy to remove the pericardium. Medical management of constrictive pericarditis is very limited. Diuretics and salt restriction do very little. They simply decompress your fluid. You don't have to have a pericardium, and if mine was like this, and it was like underwear that was 2 sizes too small, I would just remove it.